emergency psychiatric emergency psychiatric units, which leaves 41 licensed beds that are unused that could be converted to a distinct part chemical dependency recovery hospital. Why do I, put the onus on the county for this? Well, the state has made the reimbursement for chemical dependency inpatient services a third of that of acute psychiatric unit services. So you can't even get acute treatment the same as like an administrative day when you're waiting to step down. If you have a severe substance use disorder and you're too cognitively impaired, your substance use disorder is too severe to be at a social rehabilitation facility, and you need a higher level of care. Well, that just doesn't exist because the money isn't there. And I think that's so you talk about why I'm frustrated with the system. Well, I think the fact that we don't have a continuum of care is my number one reason for frustration. And when somebody is too severe for a residential recovery unit, they can either go to the streets, they can be sustained by their family through bending over backwards to try and keep them alive, or they can go to jail, or they can die. And we've seen way too many people die, and I think it's a huge governmental failure on both on the local, the state, and the federal level.
Thank you. I wondered if you would explain a little bit about naltrexone as well.
Yeah, I don't get as incensed about naltrexone, but naltrexone, it's an opioid antagonist, and it can. So if you need medications for, if you need opioid medications for pain, that's not a typical medication that you would want. And I've seen very few people have success with naltrexone for opioid use disorder. It's much more commonly used in alcohol use disorder. It's available as a long-acting injectable Vivitrol, which can be very helpful. Again, the issue with medications is that you have to take them. And if you're too cognitively impaired to maintain medication adherence, or go to a clinic and show up and fill out paperwork and sit there and be patient, you need more support and structure. So I would say medications are a very important part, but also simultaneously a very small part when you look at the broad continuum of care. And I'm hopeful that that in the future, and with CalAIM and with some of the other initiatives that the state's taking on, that we will reimburse people who provide substance use disorder recovery services at a level that can sustain and grow the substance use disorder workforce.
Thank you so much. April, the next slide. So we really need to take an honest assessment of the lack of treatment services and why, and promote a compassionate response to the overdose crisis that will reduce stigma and champion strategies that reduce the harms and save lives. I have a few follow-up questions here, and then we'll open it to Q&A. And so just 1 minute responses to my questions, if you would. Dr. Rossi, what are the ramifications you see from deregulation of methadone?
So regarding Haney's, Representative Haney's bill, AB 2115, I am not against the bill, but I just think we need to be really careful. There's not a Dr. Meyer everywhere. As you can see, he's a very special individual, special physician. I would want to make sure, there's so many questions I have around the bill. Not a requirement for counseling sessions. Where? In an OTP? Because that's like my entire model. And to, what Elon was saying, the support, the medication as a tool with the support that patients receive through a beautiful counseling component. Lost? Where? Are regular physicians' offices equipped for methadone patients? I am a specialty facility, and on my grounds, they weren't ready. And I know what I'm doing. So, are people prepared for the behaviors? I have it pulled up because I didn't want to miss a point. I really like the idea of the 72-hour prescription benefit. Like someone like Dr. Meyer, it would just work so beautifully with us, where he would be able to prescribe and refer, and it would just be such a beautiful thing. So I'm really for that, and for more of the high level, restrictive, extremely helpful SUD programs that we need to have, that Dr. Meyer's talking about. So all of that, I'm into that. Expedited entry into a treatment program. Physical exams are not inhibiting patients from getting in. Most clinics now, specifically OTPs, are not worried about a physical. They're getting people in quickly. That's something that has really happened and is done actually quite well, at least at SOAP. And I can speak for the majority of the OTPs actually in San Diego County for that one. 1 year of usage before receiving treatment. That's a ridiculous reg that needs to go away. I completely agree with doing away with that. Just a funny story real quick about SoapMat. So when I opened, I had a really good reputation with DHCS. So they granted me an ability to not have to do that. That actually existed, that people don't know about now. And I actually framed it and put it in my front office. And Mark Gonzalo, who's on this call, can speak to how devastating it was when they removed that. They actually went backwards away from even this new proposed bill and actually forced us to do the whole 2-year, and it was actually called a 2+2 exception. It negated the fact that we had to do that because of good behavior and a lack of deficiency during audits and such. So it was an honor to have that. And that was actually removed from all clinics that had that. So it made it more difficult. And this was recent. This was like 2 years ago. Mark can speak to that later, but I mean, ridiculous. So the counseling I talked about, I love the idea that a patient can be absent for more than 15 days without being discharged. I think they're proposing 30 days. I think that's great because sometimes it just takes you a while to get a patient ingratiated again. And then, yes, physicians need greater discretion for their prescribing. And there just needs to be like a Dr. Meyer to even educate these doctors. I would accept them. I would be happy about it. But some like just willy-nilly and just panicking and having people just claim to be experts in this area who aren't worries me. And also, when I started this in this modality, one of the big things that I was going against was the fact that patients and others, patients themselves, believed that we were a quote unquote juice bar, that we were only there for the medication. Again, Mark Gonzalo talks about this really, really well, about all that him and I fought when we opened SoapMat, and Kathy too, against this whole concept of a juice bar. I mean, that's what I fought for all these years. So the idea that we're going potentially backward, it just has to be couched correctly to the public. There has to be a lot of work around how this could be executed. But I think with appropriate regs around it, I think the deregulation would be really effective in getting more patients into treatment, but just those considerations need to be kept in mind.
Thank you. Thank you. And Elon, make this a quick answer. And I think that it's probably almost a one-word answer if I know what you're going to say. But why do you think the providers have been reticent to send clients tomorrow?
Well, I guess if you wanted a one-word answer, it goes back into the stigma of the whole thing. The juice bar thing is the stigma. That's why it's there. I mean, for years and years of people seeing methadone as a juice bar, a place where delinquents and throwaway people just came to get a fix and to get them on their day. That fictional story is played out over and over again in people's heads, and the people that are against it or believe that everything has to be abstinent or have some hypocritical moralistic view are going to find anyone that might slip through the cracks and overdose while they're on buprenorphine or on methadone, and they're going to take that story and run with it like that's 99% of the people at the time. Now we get into this idea where counselors know they're working there. They're like, okay, I want to get this person a counseling thing, and they're good counselors, don't get me wrong, but I know, even as me as a counselor, some when I was working at a clinic, had some really good clients and good one-on-one sessions, and then I had a lot of ones that had just been for so many years believed that recovery wasn't for them, that they didn't work on anything, that they just wanted the medication from me, that I was almost pulling teeth to make them to force them into a counseling session because they didn't believe it was for them. For years and years, it had been taught that they didn't belong in recovery, that they didn't need counseling, that medication was just another drug dealer that was going to keep them safer from other street drugs. And I mean, that's the kind of stigma up front we have to bash, but it's still in the counselor's head. So the counselor kind of wholeheartedly says, oh, there's a Mara group over there, but if they get any, well, I can't, they don't push it, and then a lot of these places, because there's more funding now in harm reduction, have, I don't send them Mara because we run a harm reduction group now. And that's not just for OTP, that's for any providers out there now. We run a harm reduction group, or we run our own group, and they're almost scared to let them go to an outside meeting because we want them to be here if they're ever going to do anything like that.
Thank you. Dr. Meyer, I know you talked about Medi-Cal, but what part do insurance companies play in not providing coverage for MAT? And before you answer, let me just tell everybody we don't have to stay to that 60-minute. I'm sure that we can all just extend a little bit because we really do want to have time for your Q&A. But go ahead. Yeah. No, you're muted.
I know the question was directed at medication. I think that how we deliver the medication is being addressed now. Now that we have mobile NTP, an option for a mobile NTP, which is great. There's currently an encampment in the San Diego River with about 40 people living on that encampment. It's like an island, and there's a whole bunch of people that need access to appropriate treatment for opioid use disorder. How do you? But that island is only accessible by kayak, and how, like, if you're going to clear out an encampment, how can you clear out an encampment if you're not providing appropriate treatment and linking people to care? And so I think that there needs to be more work done on outreach and reimbursing outreach through so that counties don't have to reimburse through local county codes, but it could be done by the state. I think we need to prioritize outreach a lot more than we do, rather than requiring a patient to come to you to see them face to face in order to bill. I think we should be able to bill for outreach and time spent trying to engage very difficult, vulnerable individuals. I think I know the DMC ODS waiver system is great, but it's a carve out. And with that carve out comes quantitative treatment limits. I think it's arbitrary that people are limited to 30 days at a residential recovery. What if they need 31 days? What if they need 32 days? And it's this hard and fast, rigid, arbitrary time limit. And you don't see that for physical health. If you need treatment for complications from a pneumonia or from some kind of an infection, it's based on your clinical course, not 30 days and then you're out. And I think that there needs to be more thought put into coordinating the system of care so that linking somebody to a residential recovery or sober living or other kind of setting is just as easy as a skilled nursing facility. Because with a skilled nursing facility, you have centralized systems, but there's no centralized system for a substance use disorder continuum of care. And so you get these hodgepodge, you have to call each facility, you've got to fill out each facility's different application. and it's a barrier. So I think insurance is one piece, and I think state oversight needs to be there.
Yeah, thank you. Thank you so much, panelists. I want to get to the questions and I'd love to see everybody's faces. So April, would you mind leaving the slide presentation and opening it up so that people can ask questions? And also, April, would you go ahead and take the questions in the chat for us?
Yes, there's no questions in the chat, but I'm assuming maybe because people want to do it with their voices.
Okay, or you can raise your hand. So if as soon as I see everybody,
Yeah, go ahead and take your cameras off if you want, or take your you can unmute yourself whenever you're ready, and then ask the question that you need to ask. So if anyone needs to ask anything, now is the time.
okay, and April, can you kill the slide presentation so we can see participants? Thank you. Perfecto. Oh, hi, I see some faces I know. Hi, thank you for being here. Okay, does anybody have any questions or comments? Because I know there's some people in the room who have experience that they might want to share, or perspectives that they might want to share. So just raise your hand and I will note calling you. Oh, I think Karen just gave a question in the chat. Let me see what that was. Karen Lanyon, did you have a question? What would be the best approach to rectify the situation Dr. Meyer just described so eloquently? Dr. Meyer.
Isn't that the question? If I had a magic wand, it'd be pretty easy. But I think that's the whole point of meeting in groups like this, to share perspectives, to educate, to engage with our elected officials, to engage with our behavioral health system in our county, to engage at the state level and the federal level. And I think that's where organizations like A New Path, are so crucial at providing not only forums for this, but also life-saving treatment, from naloxone to some of the other outreach that's being done, and to the work that Elon's doing. I think obviously no one person can do this alone, and so it takes all of us working together. Laura Rossi is opening up a new methadone clinic. I think we're all working to make this situation better, and we need to amplify our voices.
Thank you. And Maya, you have your hand raised.
Hi, yes. Hello, everyone. It was great to hear the presentations from everyone. And I had a couple of questions. One was more broad that I feel like anyone can answer. I know it was mentioned recently that to do more outreach. And I was just curious, what are your thoughts on best practices for doing outreach and finding the people? Like, where are they? How do you find them? How do you send the message to the right people? And how do you bring them in?
Okay, I can take that one because my whole background is outreach. What you do is, when you know the patient population, you know what their proclivities are, you know what they like, you know how they live, and you know where to go. And you basically go everywhere. You go all day, and you go every day, and you go hard. And you have to be able to forge relationships with people without having a judgy look on your face like this. When you walk up and you see that there's syringes in the area that Dr. Meyer's describing, that's kind of like an island, and you have to be really mindful of your body language and have a casual approach. A friend approach, real easygoing kind of demeanor. One of the things that I did at SoapMat, because my competitor worried that I was going to take patients. So I had to combat that as well. One of the things I had to do is I had to go where the patients were to find the patients. So Mark and I went on foot and on the San Diego transit system for months to recruit and find patients at camps. I mean, homelessness 12 years ago, houselessness was not where it is now. We did not have to go into, really, deep where you have to go today. It's much more of a sophisticated system that has developed now. But, the answer is actually pretty easy, Maya. I mean, you look around and you know that this particular patient population is very secretive. They're not just going to be like, having a t-shirt on with like, and going to the beach. That's not really what they're doing. They're, usually on a mission to get somewhere. And, you can tell by a stride, you can tell by the kind of candy they eat. I mean, one of the things that I had studied for years was the kind of candy that OUD patients eat, so that I could market and meet them there at the gas station, at the 7-Elevens that carried that type of candy. One of the things I noticed is that candy that is near regions that have high UD percentages is completely different from 7-Elevens or gas stations that are not in that region. So, I mean, just really learning the behavior. So I posted up at places like here in Carlsbad by the beach that had the kind of candy that my patients wanted. So I could go on and on, but it needs to be done so much more, and there needs to be for it, as Dr. Meyer said.
Elon, do you have perspective on that too? I know we do an awful lot of outreach with our naloxone, and we found that, particularly in the summertime, we carry bottles of water around with us because they don't just need naloxone. They need water. They need to hydrate. So, Elon, do you want to?
Yeah, I think she covered it, and definitely not coming from a place and watching subtle things like body language or any comment you might make, or rear and back if you see needles or trash or that kind of stuff. But if you come at them, and I think what you're saying is perfect. It's like when I go out and I'm trying to provide naloxone or fentanyl test strip or xylazine test strips, I don't just take that out there. And I take out, obviously if you're unsheltered, you're probably going to need some water, especially now that it's 1,000 degrees every day. I take snacks. If we have Band-Aids, I take Band-Aids, those type of things, just little things, and I give them to them without, even if they don't want naloxone or fentanyl test strips. And I don't ever push anything on him, but if I get any questions like, do you know how to get it to a shelter, I give them referrals that way. But I got to tell you, going back to what Aaron was saying, the lack of continuum of care, one thing that just pisses me off all the time, because I want to see people in recovery, when I find that person that might be struggling, I mean, maybe a lot of days, see the same people, they don't, all they want from me is maybe, maybe a clean pipe or a fentanyl test strip or Narcan or just the snacks that I have on me. But one day they, how can I get some care? How can I get into a program? That type of stuff. Now, Medi-Cal, you're not going to get right into a program, and if you get on a list or whatever, that means you have to call all the time. That's way out of their scope of practice. And if you don't take them when they're ready to go, you never, they might not never be ready again. We have to somehow get to a point where, if you want treatment, you get treatment. Now.
Yeah. Thank you. Was there any other questions? I love the hearts, Aaron. We're all on the same page. Well, if there are no more questions, this is recorded. We'll put this out there so that you can share it with other people that might want this information. I am so grateful to our speakers, and I love the way you relate to one another. You're all clearly very involved in this and very committed to it. And so We deeply appreciate it, and we deeply appreciate all the support of the mission and the projects that we are doing at A New Path. So thank you.
Well, friend, that's how we get it going. You know, everyone, don't be scared to talk about this stuff. Inform someone who's not here tonight. Everybody tell someone that they know that's not here tonight, and it goes further.
Right. Carry the message. Thank you, everybody.
You everyone, have a good night.
Thank you so much.